system's really funky to work with. You can have sudden intraoperative death when you're dealing with either the pituitary, adrenal, or the thymus. You can have acute antidiuretic hormone deficiency for the pituitary, glucocorticoid insufficiency with the pituitary, so that's what PIT means, okay? Failure of treatment, Cushing's with the pituitary, hypothyroidism with the pituitary. So if you get a pituitary dependent Cushing's and you go and remove the pituitary, you're going to affect all these systems. Okay, so that's kind of logical, right? So Cushing's, hypothyroid, glucocorticoid insufficiency, which is Addison's. Dyspnea, because you're having to go through the mouth. That's how we go to the pituitary. That's how you get to it. You can end up with nervous system damage or KCS, and those are all with the pituitary. If I'm going to ask you something about that, it's going to be something obvious, like, okay, pituitary controls what? The thyroid. It controls what? The adrenal gland. Okay? So I keep it simple. I think y'all know that now. Moving on to the adrenal glands, pleochromocytomas, okay? Those patients, they have very high heart rates because they have a lot of catecholamines being released. It's almost like being on edge. You know, they're like constantly freaked out state. So obviously, you go to do those surgeries, you're at risk of having acute heart failure just from having those high catecholamines. Then, if you're successful in removing that adrenal tumor, then your catecholamines suddenly bottom out. So they are really hard to deal with anesthetically, and I'm not going to do one unless I have an anesthesiologist right there. Okay. Similar to that would be hypoadrenal corticism, because you're dealing with the same organ. You don't have the catecholamines dealing with, but it's still tricky. You can have CNS complications. You can end up with diabetes mellitus, pulmonary thromboembolism, renal or hepatic trauma, just because it's in that area. And then if you're working up here with the thyroid, you can end up with hypothyroidism and hypocalcemia. If you remove the parathyroids, you got to watch your calcium. You can end up either hyper or hypo. If you're removing the parathyroids for a tumor and you don't get it all, you get the hyper. If you're successful and you remove it all, you get the hypo. Okay. Myasthenia gravis is related to the thymus, and hyper or hypocalcemia is also related to the thymus. So those are not very common things you see, but they're in the book. Okay. Abdominal cavity. They're real simple. Foreign body, you leave a sponge or an instrument. Adhesions, peritonitis, because your resection and anastomosis leaked. You could end up with pancreatitis just because you pissed it off when you were in the neighborhood. Or you can end up with pancreatitis just from putting them under anesthesia. And then the dehiscents, abdominal wall dehiscents. Those are your big ones, okay? GI system, obstruction, just messing with it can give you ileus. Like I said, pancreatitis. Pancreatitis is related to anesthesia even if you're not in the abdomen. But if you're in the abdomen and playing around in the area, it tends to get angry. You can have problems with the biliary system. If you had to do a duodenal resection and anastomosis and you didn't pay attention to where the common bile duct emptied and you left it out there flopping, you're going to have big problems. Okay? You can end up with duodenal reflux just because you did anesthesia. Doesn't have to necessarily be in GI surgery. Again, adhesions, intussusceptions. Okay? Intussusceptions are usually in young animals caused by intestinal parasites, but it also can be caused because you were in there and the bowel was angry. Short bowel syndrome, if you've resected too much. Ileus, which is not moving at all. And of course, leakage and peritonitis. And if you take too much colon, you can have diarrhea. hepatobiliary, pancreatic, and splenic. Oh, there's a bunch of them in there. So, you can either have low glucose or too high glucose. That's related to the pancreas. You can have low albumin. You can have hepatic dysfunction, ischemia. You can have bacterial contaminants of the systems. A lot of times we'll put gel foam in our biopsies of the liver to plug the holes, and there's some controversy there because the liver is known to have bacteria in it. So are we giving that bacteria media to grow on? We don't tend to see a problem with that, but we do as surgeons talk about it. Bile peritonitis, if you ever have that or see that, that's an extreme emergency and death is highly likely. If you have a ruptured gallbladder, it's bad. Okay? Stricture can be almost as bad if it goes on long enough and ends up in a gallbladder rupture. Okay? Cholangitis can happen. You can end up with duodenal ulceration, especially that's dependent on the drugs you give and the disease process you're dealing with. Like I say, pancreatitis you can get just putting them under anesthesia for a dental. When I was a student, I was a part of a study on pancreatitis and what are our risk factors, and anesthesia was a big one. Okay. You can end up with diabetes mellitus if the pancreas completely fails. If you're dealing with portosystemic shunts and you're trying to ligate it, you can end up with portal hypertension, which the blood's backing up to the gut and causes big problems. You can also have seizures, urate calculi. They can end up developing multiple extrahepatic portosystemic shunts. Those are all complications for shunt surgery. With the spleen, if you don't ligate well, you can have hemorrhage, you can have coagulopathy. Usually you have cardiac arrhythmias, but that's probably related to why you're doing the splenectomy more than actually removing the spleen. And if you're removing it because of neoplasia, you can end up with metastatic disease. Okay, it's kind of logical, right?
Does cholangitis necessarily have to come from stones from the gallbladder?
No.
Okay.
Just messing around with the system sometimes. You know, every time you touch tissue, you're causing trauma. So if you're up there messing around with the gallbladder and liver and you're a little too rough, we like to express the gallbladder when we're in there, make sure it's expressing well. If you're a little too rough, you can cause cholangitis. Okay. Biggest problems in your genital surgery is urine leakage and, I don't have it here. Stenosis, okay? You are going to see blood in the urine anytime you operate on the urinary system. Usually it's transient. If you're going in for stones, you can have complications of the stones coming back because owners don't follow your management plan. We do have stricture. Anytime you have a stricture, you can end up with hydronephrosis. Depending on what you're doing, you can end up with incontinence and cystitis, recurrent estrus, and stomach-pyometra.
Oh, you said stenosis of what?
Anywhere down the line until it drops into the bladder. Once it drops into the bladder, operating on the bladder, it's hard to cause a stenosis and a hydronephrosis. But the ureter doesn't like to be cut and sewn. It tends to stricture, and you can have hydronephrosis. Okay? So, for recurrent estrus and stomach-pyometra, that's when you've spayed them and you left ovary behind. So when I teach y'all how to do spays, I will teach you how to prevent that from happening. Because you have to have some ovary tissue to cause pyometra. Okay? Prostatic cyst has its own categories of things that can go wrong. In addition to urine leakage, you can have urethral-cutaneous fistula, you can have chronic UTIs. They usually are incontinent once you've operated on the prostate. You may have persistent drainage if you marsupialize them. And for prostatectomy, leakage, stenosis, infection, recurrence, and incontinence. Okay? And I will teach all those diseases next year. perineal area, fecal incontinence, anal stricture, sciatic nerve entrapment, urinary issues, and recurrence. Perineal hernias have a high risk of recurrence just because there's nothing back there to hold it in. Okay? Spinal surgery. You can make them worse. Okay? Most of the time we do make them a little bit worse. You have lack of response. Even if you did a perfect surgery, that spinal cord is so damaged you're not going to get a result. You could get complications secondary to corticosteroid use. I've had a couple of them had GI ulcers. Okay. You can have perioperative mortality. The other big thing for spinal lesions, especially disc, is the domino effect. Disc and fusions. So you operate on this disc, the next disc down the line ruptures, or if you fuse this one, the next one down the line becomes unstable and has to have a fusion too. Same complications in humans. That's why I haven't let them operate on my neck. Fractures. In addition to everything else I've talked about, hemorrhage and infection, you can have delayed union, non-union, malunion, nerve entrapment, avascular necrosis. If it involves a growth joint, you can have premature closure of the growth joints and abnormal conformation of the limb. And a big one I'll teach you about next year in orthopedics is quadricep tie down. Basically, that leg is straight and they can't bend it. That's malpractice. That's why we don't put them in a straight leg splint. We put them in a natural standing angle. And that's it for that one. Okay, real quickly, medical records. I think I can do it in 15 minutes. Okay, patient or problem-based oriented veterinary medical record. That's what we mean by POVMR, if you ever see that written. So why are they important? Well, it's a record of what is seen, done, tested, the results, recommendations, client education. It's a communication method between doctors and technicians and other staff members. It's a legal record. A legal record. A legal record, okay? If you're worried about malpractice or losing your license, keep good records, okay? If it isn't written, it wasn't seen, done, or said. Yes, ma'am?
Question, is this on Blackboard?
If it's not, I can put it up there. I thought I put it up there because I wrote it quite a while ago.
The complications one is on Blackboard, but this is on.
Okay, well, I'll get it up there. I may have put it in the wrong file. Okay. Medical records are required for research and teaching records. And the main reason why I'm doing this is because it takes me forever to get junior surgery students to do good medical records. So I'm giving this to you now, so you can think about it over the summer. If we have junior surgery like we've had it in the past, I'm going to grade you on your records, okay? Because I want y'all to learn how to keep good records. All right? If not, Martin's going to nail you in clinics, okay? She will harp on you for your medical records, no end. Thus far, I haven't heard too many complaints, so it must be working. All right? Yeah, I said that. So we have to have it for the junior surgery dogs. We'll see if it continues the way it is. Okay. With that said, there's certain things in that medical record that are protected. That's the client information. Okay? Protected personal information. There are laws that govern this to protect people's privacy. Client information should not be given out without the owner's consent. Do not include it in grand rounds, okay? You can talk about the patient all day long, but none of the client stuff, not unless they give you authorization. Next, you're going to have a history. A global history, housing environment, vaccine record, heartworm tests, other tests, preventative, other animals in the house, diet, exercise, history of previous illnesses, diseases, injuries, or surgeries. Okay, that's just in general. Then you gotta take a history that's specific for the problem they came in for. If they came in for a problem. If they're just coming in for vaccines, then you don't have any other history. So when you want to talk about that specific problem, you want to talk about the duration. Is it acute or chronic? Is it progressive or not? Okay? Is it episodic or not? He limps on Tuesdays and Thursdays, but not Monday, Wednesday, Friday. Okay? Response to any previous treatments, any previous diagnosis, etc. And then you're going to go into your physical exam. Okay? You have a generalized physical exam, your TPR, listen to the chest, palpate them all over, palpate their abdomen. But then you have specialized tests, orthopedic exam, neurologic exam, ophthalmologic exam, otic exam, bless you, dermatological, and you'll learn all these next year, okay? So here's our history form. This is for us. And down here's all the things they want you to go over. This is kind of tedious for most of what I see, but this is the way we do it, okay? You want to fill it out, okay? Don't just put limping on hind leg. Put A1, hind limb lameness. 2, first occurred a month ago. B is sudden onset, has not gotten better or worse. C and D are none, that's treatment and drugs. 3 is basically how long you had since a puppy, never been out of Alabama. When was the heartworm test? What is it on preventative wise? See above, blah, blah, blah. You want to put just a little brief note there, you know. You let the clinician know you answered that question. Obviously, your junior surgery dogs, you don't have anybody to get a history from, okay. Make sure you fill out the bottom, okay. Next is your physical exam, and usually that's on the back side. Or I make it on the back side for junior surgery to conserve paper. Here is your general outline. NAF means it's normal. AB means abnormal. Okay? Once you have the AB over here, you go MS dash, toe touching lane. Once I put this on whiteboard, you'll have it as an example. Be sure to fill all this out at top. You know, orthopedics, right hind lameness. For junior surgery, it'll be general surgery, presenting complaint, junior surgery dog, admission date is the date you got it, okay? Now, here's the stuff I really want y'all to pay attention to. This SOAP format. This is so hard to get through, you guys. So, S means subjective, okay? For your junior surgery dogs, junior surgery dog. That's it. For your patients that come into the clinic, it's whatever their presenting complaint is. Owner's complaining of left hind limb lameness, vomiting and diarrhea, whatever, okay? Almost synonymous with CC or chief complaint, because some people do that too, okay? It's what the owner's complaining about, things that are not necessarily measurable, okay? Not necessarily measurable. Your objective is the stuff you can measure, so your TPR, your body condition score. If they bring in a fecal sample, you can score that fecal sample. We have charts in the clinic that show you it's a 9, or it's a 5, or whatever, okay? Slightly subjective things, but subjective things that we as veterinarians think are actually objective, like mucous membrane color and CRT. You know, you really can't scale that, but you can say it's pink, less than 2, or it looks cyanotic, or it's pale, okay? So, left hind limb lameness, toe-touching lame, or grade 3 out of 6 lameness. There is a grading scale for lameness. I palpated the hip and I found out that the iliac crest, the greater trochanter, and ischial tuberosity are all in a straight line. Okay? That's not your diagnosis, but that can lead to your diagnosis, because that tells you it's a cranial dorsally luxated hip. So, out of this you're going to have problems. Okay? So problem 1 is skinny, problem 2 he's got diarrhea, problem 3 he's left hind limb lameness, and I've got a straight line from those bony points, okay? So your assessment is going to be your differentials. For being skinny, he's not being fed enough, or maybe he's got parasites, or maybe he just is overactive and is burning off all his calories. 2, for his diarrhea, well, maybe he's got parasites again. It might be stress, it might be dietary indiscretion. 3 is his left hind limb lameness, and cranial dorsally luxated hip better be number 1 if you've got what I just described. Wing of the ilium, greater trochanter, and the ischium all in a line, because they're supposed to make a triangle. Okay? So that's your differential diagnosis by problems. Problem 1, 2, 3. Then in your plan, same thing for each of your problems. Your plan is either diagnostic or therapeutic or both. We're going to run a fecal. If positive, we're going to treat for internal parasites. For the hip, we're going to take a radiograph, etc. Okay? And that's what's on this sheet. This is blank, and I think I have one filled out. This is how the Army taught us to do them. Okay? Same way. Chief complaint, we're doing a lab posting. Subjective, not NA, not applicable. O, see lab report forms. CBC is normal, UA is normal, chemistry slightly increased cholesterol, slightly increased T bilirubin, lipemic, and hemolyzed. Chest red's normal, echo, mitral, regurg. Then down here they start doing the problems. Murmur, normal reds, not clinically of concern. ACE inhibitor might be helpful. Problem 2, he's got orodontal disease, routine and mild, no treatment needed at this time. Problem 3,